This program is brought to you by Emory University.
Good morning, everybody. Happy Friday morning. As you can see this morning, our speaker is Dr. Talha Ijaz, one of our, he's in his fourth year, I guess, of fellowship after 3 years of research, first clinical year. Talha did his medical school at University of Texas Medical Branch in Galveston, then joined us here at Emory as part of the ABIM research track, did basic science research with Dr. Michael Burke. He's going to talk to us today about I guess the Impella microaxial flow pump and cardiogenic shock. Take it away, Talha.
All right. Well, thank you, Dr. Williams. Glad everybody who could make it this morning for the presentation. Really, the presentations today is inspired by a recently published article in the New England Journal of Medicine, in which they evaluated microaxial flow pump, or Impella, in cardiogenic shock after a myocardial infarction, with some very surprising results. Those were some results I wanted to share with everybody today. So I have no disclosures. The objectives for this talk are to review the major clinical studies that have evaluated microaxial flow pump, or Impella, in cardiogenic shock, the studies that eventually led to the most recently published in NEJM, and then review the most current guidelines regarding the use of mechanical circulatory support in cardiogenic shock as well. And lastly, I'll finish off the presentation with delving into the DanGer shock trial that was published recently and its implication for clinical practice moving on. So to begin with, this is a common patient scenario that we run into as general cardiology fellows, or even fellows rotating through the cath lab. So there's a patient, JS, who's 70 years old, has a history of hypertension, diabetes, and known coronary artery disease, on optimal medical therapy, presenting now to the emergency department with acute chest pain. When he's examined, his blood pressure is on the softer end of things, 95/63. His heart rate is still within normal limits, but a little bit tacky for his from his baseline at 95. He's breathing okay, but his sats are slowly dropping, currently at 93%. On physical exam, you find him to be mildly diaphoretic. He's still in chest pain and complaining that it's left-sided and not going away, despite of whatever maneuver he attempts. On cardiovascular exam, his heart rate still regular rate rhythm. He does have an S3 gallop. He has a soft holosystolic murmur at the apex. When you touch him, you find that his extremities are cool, and on the lung exam, you find that he has crackles from mid to lower lung field bilaterally. Examining of his lab shows that his troponin continues to jump up from baseline, and at 1 hour time point, at 3 hour time point, it's already up at 3,000. His BNP is elevated at 2,000, and he has a small lactic acidosis at 2.7. His EKG is indicating he has ST elevations present in the antral septal leads in V2 to V4, and he does have T-wave inversions in the lateral leads of E5, E6. You POCUS him and find that his EF is low at 25%, is dropped or even present for the past month at this low point. He does have some regional wall motion abnormality, and it seems like he has hypokinetic anterior wall. So pretty classic presentation, and this gentleman's having a anterior wall STEMI, and the likely scenario is that this patient's going to be rushed from the emergency room to the cath lab for a PCI. At the same time, one of the questions that is asked is someone who is not only having a STEMI but appears to be in cardiogenic shock. Would a patient like him benefit from mechanical circulatory support? And would that help increase or decrease the chances of mortality in the coming hours to days? And as far as mechanical circulatory support is concerned, there are different devices that have been utilized in cardiogenic shock. And for the purpose of this talk, the main device I'm going to focus on is Impella. And in this talk, because authors of different studies utilize different terms for Impella, Impella, microaxial flow pump, are going to be interchangeably used, but again, it's referring to the same device. So the Impella is a device that's usually inserted to the femoral artery. It's guided up into the left ventricle, where when it's situated properly, it helps pump blood from the LV into the aorta, thereby helping blood return both to the coronary circulation, to the heart, and also helping blood flow to the rest of the organs throughout the body. Impella is also known to alter hemodynamics in cardiogenic shock. In cardiogenic shock has been defined as systemic hypotension, usually systolic blood pressure of less than 90 millimeters of mercury, with cardiac index usually less than or equal to 1.8, elevated filling pressures, usually right-sided and left-sided, and then associated systemic signs of hypoperfusion, such as lactic acidosis, cool extremities, and decreased urine output. So in this situation, when a patient has cardiogenic shock, there is a high chance of mortality due to this acute myocardial infarction. And most studies have pointed out the patients usually have a mortality rate of 50 to 60% within the first 30 days. And when the hemodynamics of patients are assessed, who are undergoing cardiogenic shock, we're able to see the changes that occur on a pressure volume loop. So here I presented a classical pressure volume loop in which the end diastolic pressure, is represented by the rightmost corner, and as during the cardiac cycle, as there's isovolumetric relaxed contraction, there's decrease in the volume and decrease in pressure. Eventually, there's isovolumetric relaxation, leading to increased return of blood flow back into the LV. This cardiac cycle or area under the curve usually is represented by the stroke work in each cardiac cycle. Addition of stroke work plus potential energy gives us the pressure volume area. And this pressure volume area is directly proportional to the myocardial oxygen consumption that takes place within the heart, per heartbeat. In cardiogenic shock, this pressure volume loop is modified, where it's moved both to the right and also is decreased from the top. So shift to the right and also below the original curve. This represents both decrease in contractility and increase in peripheral vascular resistance that usually accompanies cardiogenic shock. And in cardiogenic shock, the myocardial oxygen demand is increased, putting more stress on the heart muscle to provide the necessary oxygen to each muscle fiber. When a mechanical circulatory support, such as Impella, another word for it is LVAD, is utilized in a setting of cardiogenic shock, it helps this pressure volume loop in the cardiogenic shock state move back a little bit to the left and also decrease from the top. The total pressure volume area or myocardial oxygen demand is represented here by the red loop, and with implantation of an Impella device, as the curve shifts to the left, you're able to see that the total amount of pressure volume area and therefore the myocardial oxygen demand decreases, and therefore allows the heart some more time for recovery back to its original state. So there are multiple hemodynamic benefits of Impella and cardiogenic shock. As I mentioned, that one of the primary benefits is that it unloads the ventricle by decreasing the left ventricular and diastolic pressure and volume, thereby decreasing myocardial wall stress, and indirectly then also decreases myocardial oxygen consumption. The downstream effects also include decrease in the wedge pressure and the RV afterload, and increase mean arterial pressure and cardiac output. The overall goal of this mechanical circulatory support is to allow better perfusion of both the heart and other organs throughout the body. Keep in mind, though, that for the Impella to work efficiently, it is dependent on oxygenation of blood that should be properly done via the lungs, and also an intact RV function. In absence of these two important factors, Impella is likely not going to function properly. The Society for Coronary Angiography Intervention has developed a classification for cardiogenic shock, in which a patient is considered to be in stage A or at risk if they're still normotensive and have a cardiac index greater than 2.5 and their normal renal function is still at baseline with no elevated active lactic acidosis. Stage B is usually defined as having systolic blood pressure less than 90 with the mean arterial pressure less than 60. Again, at this point in time, still having normal renal function and lactic acid levels. Stage C is defined as when the systolic blood pressure has dropped below 90, the mean arterial pressure is less than 60. At this point in time, the lactic acid is usually greater than 2, and there's signs of acute kidney injury and acute liver injury occurring. And with if there's hemodynamic measurements taking place, you would usually see that the cardiac index has dropped below 2.2. Stage D is where usually a patient has progressed to requiring multiple pressors or even mechanical circulatory support to maintain perfusion. And stage E is where the patient has become hypotensive despite all the mechanical support and inotropic support that may be provided. And usually at this point in time, patient is severely acidotic and their lactic acid is rapidly climbing. So one of the first studies to evaluate percutaneous mechanical circulatory support asked a question where this mechanical support helped improve hemodynamics after cardiogenic shock from an acute myocardial infarction. And this was the ISAR shock trial, which was published in 2008. It was a European-led study in which the objective of the study was to assess whether Impella LP 2.5 would provide better hemodynamic support than something such as an intra-aortic balloon pump in acute myocardial infarction-associated shock. This was a prospective two-center randomized trial, and there were a total of 26 patients that were recruited for this study. 13 were directed towards the Impella 2.5 group and 13 towards the intra-aortic balloon pump. And the comparison was between these two groups. The primary endpoint the authors looked at was the change in cardiac index from baseline within 30 minutes of device implantation. And the secondary endpoints were biomarkers such as lactic acidosis, hemolysis, and 30-day mortality. So overall in this study, Impella 2.5 increased cardiac index within 30 minutes of implantation. So looking at cardiac index at baseline, which was about 1.7 liters per minute per meter squared, it increased from 1.7 to 2.2. This was about a 0.49 unit difference, and it was statistically significant compared to the balloon pump group. The other interesting thing that you'll notice here is that in the Impella group, there was a big increase in the mean arterial pressure from 78 millimeters mercury to 87 millimeters mercury, about 9 units difference. And this was different compared to the readings that were taken with the balloon pump, where there was not that huge of a jump in the mean arterial pressure. It went from 72 to 71 after implantation. There was a significant difference between the two groups in the diastolic blood pressure that was noted after the device implantation, where there was a significant decrease in the diastolic pressure with balloon pump compared to Impella. The Impella seemed to be also slightly more effective, not statistically significant, but slightly more effective at decreasing the wedge pressure from 22 to 19. And then also both devices were effective at decreasing the systemic vascular resistance. And again, there was no statistically significant difference between the two groups. More specifically and notably, after 30 minutes, the change in cardiac index between the two groups was the same. Or rather, within 30 minutes, there was a higher change in cardiac index with Impella compared to balloon pump, but within 4 hours, this difference had gone away, and there was no, both groups had a similar level of cardiac indices that were demonstrated. Furthermore, when the authors looked at serum lactate levels, they found that both Impella and balloon pump led to a sharp decrease in lactic acidosis within the first 24 hours. But overall, there was a trend that Impella had a smaller area under the curve, suggesting there might be some more rapid improvement in clearing the lactic acid from the body with Impella compared to a balloon pump. One of the side effects of using Impella is that there can be hemolysis within the circulatory system, and that's also was notable in this study, where within the first 6 hours, Impella support led to increase in free hemoglobin, but this free hemoglobin levels were normalized within a 24 to 48 hour timeline. So suggesting that although there is increased hemolysis, that this is not a persistent problem after implantation. And as far as the more as significant endpoint of mortality and survivability with these two devices, the author found that there was no significant difference 30 days after implantation between the Impella group and the balloon pump group, where there was noted to be similar mortality level after completion of the study. When the authors looked at a SOFA score, sepsis-related organ failure assessment, they found that both initially at baseline, both groups had similar level of score, suggesting they were, both groups of patients were severely ill, and within 30 days, the SOFA score had significantly decreased, suggesting that there is improvement in overall assessment of the patient with either device, either Impella or intra-aortic balloon pump. So in summary, this was the first trial to check the feasibility of Impella 2.5, and it showed that it can be utilized after acute myocardial infarction leading to cardiogenic shock, and there was no device failure noted, no major bleeding event or limb ischemia. And they validated their initial assessment within 30 minutes with improvement and cardiac index noted. But this cardiac index improvement that was more in the Impella group seemed to dissipate or equalizes with the balloon pump group within 4 hours. Similar mortality was observed with either Impella or balloon pump after 30 days of implantation. An increased hemolysis was observed in Impella 2.5, requiring some more transfusion of packed red blood cells. There was a lack of differential effect between the two groups, and a couple of reasons that could account for that. One thing is that the study was not sufficiently powered to analyze mortality at 30-day time point. And the other thing is that Impella 2.5 does have inherent limitation of improving cardiac output by about 2.5 liters per minute, and authors postulated that possibly, more powerful devices that have a higher output might do better in trials that look at efficacy and mortality. This, after the study was published 2008, we had a lag of period where there was no prospective trials, but then in 2018, another study was published that evaluated percutaneous MCS, basically an Impella, and looked at mortality after cardiogenic shock from acute myocardial infarction. This was the IMPRESS in severe shock trial, and the objective was to assess the difference in mortality and safety in patients who develop cardiogenic shock from STEMI specifically. But this group also narrowed down their patient selection to mechanically ventilated patients before deciding on treating these patients with either Impella or intra-aortic balloon pump. This was a multi-center, open-label, randomized prospective trial with the primary endpoint of 30-day all-cause mortality and a secondary endpoint of a 6-month mortality. In this patient, more patients were enrolled. 48 patients were divided at 24 patients into the balloon pump group and 24 into the Impella group. There was only one loss to follow-up in the balloon pump group but none in the Impella group. And surprisingly, due to kind of a stricter criteria of enrolling patients who were mechanically ventilated, this study ended up enrolling a significant amount of patients that had a cardiac arrest, prior to being put on mechanical ventilation. So almost 100% of the patients in the Impella group had a cardiac arrest before randomization, and about 83% in the balloon pump group had a cardiac arrest event. And then the average time before resuscitation in the Impella group was about 21 minutes and about 27 minutes noted in the balloon pump group, suggesting that there was a significant portion of time during where the body of the patient had not was not receiving sufficient blood flow to perfuse different organs. And thereby, when the lactate levels were checked in both groups, they were significantly higher compared to previous studies, and about 7.5 in the Impella group and about 8.9 in the balloon pump group. Then, moving on towards the results of the study, which showed that the 30-day all-cause mortality between the two groups was not different. Mortality rate was noted to be about 46% in the Impella group and 50% in the balloon pump group. And the 6-month mortality, again, was also very similar. Importantly, the authors do point out that as far as the cause of death in both groups, it was about 46 to 50% primary cause of death was brain damage. And a much smaller portion died from refractory cardiogenic shock. And this may have affected why there was not a differential effect seen between the two study arms. In summary, this was the first study to evaluate Impella CP versus balloon pump and cardiogenic shock, but again, it mainly focused on mechanically ventilated patients. There was no difference in the 30-day and 6-month mortality between the two groups. And major cause of death in both groups was actually brain damage. And the possible reasons for lack of differential effects could be that MCS after neurological damage has very limited benefit. Post-cardiac arrest and severe lactic acidosis suggests that multiple organs are under an inflammatory response and are dysfunctioning. And therefore, at this severe stage, mechanical circulatory support may also have very little added benefit. And again, Impella CP also provides a limited output, and authors postulated that possibility of something such as Impella 5.5 that has a higher output might be more worthy of providing a mortality benefit compared to the Impella CP. And based on these studies, specifically the 2008 study, ACC and AHA had come up with recommendations for use of mechanical circulatory support, specifically in this setting of STEMI-associated shock. And it was a class 2A recommendation to use an intra-aortic balloon pump in patients with STEMI and cardiogenic shock when pharmacological therapy was not enough. And it was a class 2B recommendation that if an alternative LV assist device such as Impella could be considered in patients who have refractory shock. So again, not a high recommendation to use mechanical circulatory support such as Impella after a STEMI-associated shock. And in this setting, the most recent study came out in which the question being asked was, does percutaneous MCS with Impella help decrease mortality after cardiogenic shock from a STEMI? So this question was asked in the DanGer shock trial. In this study, the authors were more rigorous in defining shock from STEMI. They noted that ST elevation on EKGs have to be less than 36-hour duration. Patient should be hypotensive with systolic blood pressure less than 100 or requiring vasopressor support. There should be end organ hyperperfusion shown with elevated lactic acid greater than 2.5, and the EF of the patient should be less than 45%. These authors excluded patients who had outside of hospital cardiac arrest and were comatose with a GCS score of less than 8, if there was overt biventricular failure, and if another specific etiology for shock was identified, such as sepsis, PE, or hypovolemia. The authors screened over 1,200 patients, and then eventually, after excluding a significant portion of them, they randomized about 360 to either standard of care group or patients that were to receive microaxial flow pump or Impella, about 180 in each. And of these two groups, there was only a small crossover from the standard of care to the Impella group, and not a huge dropout in either arm. So importantly, their baseline characteristics were very similar in the two groups. The median age was in the high 60s. Majority were male with classic risk factors for coronary artery disease, and patients also were noted to have a low EF, about 25% on average at the time of enrollment. Further characterization of these patients as far as angiography is concerned showed that they had, both patients with one vessel, two vessel, three vessel disease were enrolled equally in both arms. And patients were enrolled, during multiple phases of, presentation to the hospital. They were randomized to either arm before revascularization, in the cath lab after revascularization, and up to about 12 hours after departure from cath lab. And these patients were evenly split between the two groups. And surprisingly, what these authors were able to show is that Impella or microaxial flow pump helped to decrease all-cause mortality within a 6-month period. In this graph on the left, all-cause mortality for standard care alone at 6-month time point was by about 58.5%, compared to in the patients that received the Impella plus standard of care, there was a significantly less mortality noted. This was about a absolute risk reduction about 13%, and calculated number needed to treat. It was about 8 patients were needed to be treated with an Impella to prevent mortality at 6-month time point. Authors also looked at secondary composite cardiac endpoint, which was either escalation to another MCS, heart transplantation, or all-cause death. And again, similarly, there were results showing that Impella had improved secondary endpoint, at 52.5% compared to 63.6% noted in the standard of care alone. When looking at the subgroup analysis from the study, authors were kind of surprised to find that there was about a more significant benefit in male patients, where they had about a 34% reduction in all-cause death compared to females. There was also a significantly lower mean arterial pressure with within the Impella group, decrease of about 39% in the MAPS. It seemed that patients who had multivessel disease seemed to have a slightly more benefit with about a 32% reduction in all-cause death with Impella support. And just as importantly, authors were able to show that there was equal amount of time spent on mechanical circulatory support, and mechanical circulatory support with Impella was able to be weaned off successfully in majority of the patients, with median duration in both groups to be about 60 hours from the time of implantation. There was noted to be more mechanical Impella-associated hemolysis in the Impella group, but relatively low level of malfunction was noted in both Impella and the standard of care alone. When looking at the adverse events associated with each type of treatment, authors utilize a composite safety endpoint of severe bleeding, limb ischemia, hemolysis, device failure, or worsening aortic regurg, and found that in the Impella group, there was a significant increase in this composite secondary endpoint compared to the balloon pump group. And in this case, the number needed to harm was 6 patients, suggesting that there is this downside of using an Impella in cardiogenic shock. Other separate secondary endpoints were also noted, such as moderate or severe bleeding, and again, seems to be a trend towards higher rate of incidence in the Impella group. Likewise, limb ischemia, renal replacement therapy, and sepsis with positive culture all seem to have a trend, a higher trend in the Impella group compared to the standard of care alone. And the authors noted these 2 groups both had significant death still occurring at the 30 and 6-month time point. But unlike previous study, a majority of the deaths were occurring due to a cardiac cause or cardiac failure. And very limited numbers had overall death from a neurological cause, suggesting that really this might be a utilization of Impella earlier before the patients develop cardiac arrest or multi-organ failure would be the appropriate time point for assessing mortality benefit. So in summary, in this DanGer shock trial, a patient that received mechanical or microaxial flow pump, such as Impella after STEMI-induced cardiogenic shock, had improved mortality at 6 months after initial implantation. Also, Impella use was associated with increase in bleeding, hemolysis, limb ischemia, and renal replacement therapy. And majority of the patient death in both group was due to cardiac failure. There are certain limitations in this trial. One thing is that the statistical significance could be easily lost if there was a change in 2 patients, 2 more patients dying in the Impella group, or 2 less patients dying in the standard of care group. There is also a strong signal for harm, with number needed to harm being 6 compared to the number needed to treat for mortality benefit being at 8. And in this study, there was no data provided as far as hemodynamic measurements go, which kind of prevents us from determining how the Impella might have been truly beneficial in the cardiogenic shock state and provided the most benefit. The inclusion criteria for this study was relatively strict, and so the study cannot be applied to cardiogenic shock in patients that leads to a coma, an MI without ST elevation, and shock that is due to a biventricular failure. Study was conducted in Denmark, Germany, and the UK with limited racial and ethnic diversity noted by the authors. This was a non-blinded trial, so the operators who treated the patients, knew exactly what the patients was getting, and there could be a potential treatment bias. And that study was funded both by Danish Heart Foundation and Abiomed, the maker of Impella CP. The future implications from this are one, that there's possibility of more utilization of Impella in cardiogenic shock from STEMI moving onward. But I think a larger trial is still needed for further validation. As multiple authors in previous studies have noted, that mechanical circulatory support still has to be individualized to the patient and the scenario. So this has to be kept in mind before a device is selected for a patient. This might be the most important thing to consider when evaluating patients that are coming in for assessment. And I'll take any questions.
Stan Sherman, just a quick question about neurologic outcomes. Did they say that just because you live doesn't necessarily mean that neurologically you're intact afterwards? Did they mention this at all?
So they didn't really delve into the how the patients were, if they survived that 6-month period. There was not really a discussion on how intact they were from a neurological standpoint.
These patients, though, this is Neil Dicker, just to address that particular question. These were patients who were neurologically intact to start with. So this is not a post-arrest comatose population like you saw in press and whatnot. So there's not really a strong reason to believe there would be neurologic impairment. I think it's described in the supplementary tables, but that wasn't the issue in this population.
So this is DanGer Rab. First of all, these trials for arrest and shock are very difficult to do. This took 10 years to do, and I think to repeat this trial would be extremely difficult. Secondly, there is a mortality advantage, but only in select patients. You really can't put this device in everybody and expect good outcome. So if there's careful patient selection, then I think you'll see a benefit. The other thing you have not pointed out is that the majority of these patients are above 60 years of age. So you have to be very selective in whom you do. This is not Impella for all, but really in the SCI, CD, and E group. And exclusion, one thing you didn't point out is that they did exclude people with mechanical complications also, along with right ventricular failure and out-of-hospital cardiac arrest. So the utility will increase, but I think it has to be in a very selected group of patients. It's not for all. And, obviously the complication-related device size, a lot is dependent, the device size will change as we decrease the size of the catheter. As you know, the 9 French ECPs catheter has been used for high-risk PCI trials. If they decide to use that kind of device and shock, then of course the complications were similar to use a balloon pump in terms of groin complications, etc. I don't know if it'll help hemolysis or not, but I think sizing down the device will be a game changer in the future. And the final thing is, balloon pumps are not being produced as they used to, so we always have a shortage of balloon pumps. And if we need something in a hurry, this is the device to go to. So I think the caveat will be, so the question is for you, Talha, do you agree that there will be selective use, or do you think there should be generalized use, or what do you think? What's your conclusion? Where should we use devices and when should we use it?
Oh yeah, no, I agree. I think the authors, had a very selective group of people in which they excluded. There was a huge exclusion criteria in patients who were comatose or shock greater than 24 hours, RV failure. All these patients were excluded, and so I think when selecting a candidate for possible Impella, I think you would have to kind of match this criteria to make sure that the patient gets true benefit.
Neil, Dicker, did you have more input?
Yeah. So just a couple of quick things. I think I think the point's well taken that this isn't a benefit that's seen in every population. I think you have to watch the subgroup analysis in a small trial. It's hard to know how much it tells you. And I think, while this is a selected group, I think it's really important to note that, the IMPRESS trial, for example, was, largely viewed as not a very helpful trial because patients were too sick. So this, I think, is the population. They enrolled the population that's plausibly benefited by the device. So I think it kind of aligns with clinical judgment in that sense. The other thing I think just important to recognize, and Sunil Rao pointed this out in his editorial with this piece too. There is an ongoing trial. It's just getting started called Recover 4. That is a randomized trial of pre-PCI Impella versus standard of care, which can include ECMO. It is, we'll be interested. It's being done as an international trial. It will be interesting to see what enrollment is like for the study, especially after DanGer Shock was positive. But I think it's importantly not a trial of mechanical circulatory support versus not. It's really a trial of mechanical circulatory support with upfront Impella versus ECMO as a backup. So I think it will be a larger trial. The sample size is more in the range of 600 to 800. It's an adaptive design, but that is getting underway now, and so there will be interesting to see what happens with that. I think there are some challenges with that, especially as to whether people are going to be willing to enroll patients in a trial after DanGer Shock was positive. But for the reasons that you mentioned, there are questions about whether it, exactly how strong the benefit really is in a broad population. And certainly if you look at examples like the MitraClip with COAPT and Mitra FR, you had two highly conflicting trials in what were largely similar patient populations with minor differences. So there is some value in repeating trials. So it'll be interesting to see what happens with that moving forward.
Hello, this is Khosrow. A great presentation. Our European and Asian colleagues still are very skeptical about Impella. And so I think the current trial, which Neil is mentioning with the ECMO, I think Impella has decided to go on against ECMO rather than continuing trials with a balloon pump. But outside states, the use of Impella is not to the same extent as it's used in the US.
So two other things, we hang our hat on just one shock trial from 999 with Hockman about early revascularization and shock, which is of benefit. So those kind of trials have not been repeated. So I think the size of the trial, while it's of concern, there still seems to be benefit. One thing that's not beneficial is we've seen 3 ECMO trials and 1 balloon pump trial, IBP2 trial, that have shown no benefit in acute cardiogenic shock. And yet we put a lot of ECMO, particularly in our institution, in a situation like this. So clearly, those 3 ECMO trials, 1 balloon pump trial, not shown to be a benefit. At least in this trial, there is a mortality benefit. And try to repeat this trial would be somewhat difficult. Let's see what the Recover 4 trials show, but that will be a long time before it really is released.
All right. Well,
one other thing I'd mention, Robbie, just
Yep.
Sorry, I don't mean to interrupt, but one other thing that I think is at least worth mentioning is, and the authors discuss this nicely in the paper, but the complications are, important not to ignore. Tanvir mentioned the fact that the ECP device, which will be a smaller catheter, may have some benefit in terms of reducing limb ischemia and other leg complications. But there is an interesting question of it's sort of a competing hazard, right? In the sense that the way you get renal failure and bleed is if you're still alive. And so there is an interesting question as to whether, especially the renal failure, side is a function of people living longer and being alive to experience it versus not. Obviously, there's the issue of hemolysis causing the renal failure too, but I think it's an interesting example of where you have to think carefully about how to weigh the number needed to treat and the number needed to harm, especially the notion that you can only be harmed if, you know, it might be better to be harmed and alive than not harmed and dead. So it is an interesting tension that's important to contextualize properly.
All right. Well, thank you everybody for tuning in today. Thanks, Talha, for a good review on a emerging topic, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.